So my talk today on this subject is really to introduce you and maybe open some eyes about available innovations and tips on implementing them in an outpatient setting. Obviously, again, a 20-minute presentation, so very difficult to go over all of the evidence for all of these new devices, but the evidence is there, and hopefully you're able to implement and adopt. So how did I come about this topic? I was tasked with trying to work with a publicly funded system for disposable equipment, which is sometimes a challenge because of cost. And despite the clinical evidence to bring them into our portfolio of patient offerings, we had to go through an uphill battle. So these are my objectives: to try to really share some strategies to successfully establish an outpatient procedural clinic, to review some of the technologies and techniques for global endometrial ablation, review hysteroscopic sterilization with eSure, some advanced hysteroscopic morcellation tools, and then really to discuss protocols for effective and adequate sedation and analgesia, and really to look at a high quality patient experience. We'll start with endometrial ablation. So certainly AUB, abnormal uterine bleeding, is one of the most common complaints in the gynecology office. There's definitely difficulty assessing changes in volumes by patients. I think from the 60s, the P-Black studies in terms of pictograms, patients do not understand the level of bleeding very well. They get used to having heavy bleeding and they perceive that their bleeding is normal. Tolerance is also very variable. Talking about pad count, some patients change their pads when they're soaked, some patients change their pads when it's stained. We also know that mood effects can also appear as a factor. So certainly when women complaining with abnormal bleeding, talking about anxieties, depression, or fears of cancer, as we talked about before as well. And really technology and development of highly absorbent gel pads can also mask some of the symptoms of heavy bleeding. If we look at the prevalence, we generally see it up to 1/3 of reproductive age women. Certainly as women are getting older in their age, we do see increased prevalence of bleeding disorders. In the US, about 1 to 12 billion direct and indirect healthcare costs. Extrapolating to Canada, about 100 to 120 million. And extrapolating further, probably about 20 to 30 million US here in Kuwait. Obviously, missed work, school, absenteeism, social impact, the ability to not go out and hang out with your friends or even go and have business meetings. These have not been established in terms of a cost effectiveness or a cost to these patients. Obviously, the purpose was not to talk about AUB, but how to really develop ambulatory strategies to help women. So when do we move on to endometrial ablation? Obviously, if they failed, medical therapies or suboptimal response, there's contraindications or side effects to the medical therapy. They're dissatisfied. It's not enough in terms of their quality of life. The alternatives such as a levonorgestrel IUS, is unacceptable in terms of cost, or they don't like the side effects. Hysterectomy is too risky due to other comorbidities, or patients feel that hysterectomy is too invasive. So certainly indications are AUB of benign origin, although there is some loose literature about resecting endometrial hyperplasia in grade 1s, but we won't go there. In the context of this discussion, benign pre- and perimenopausal women, obviously not postmenopausal women, intolerance of failure of medical management, or a patient preference. Contraindications, obviously pregnancy, cancers, fertility preservation, and coexisting pelvic infection. I think levonorgestrel IUS has been a game changer or radical development in the treatment of AUB. In Canada, it is Health Canada approved for the management of heavy menstrual bleeding. And I think it's definitely a cost-effective solution compared to endometrial ablation. Although we now see the Scandinavian experience where they've had women who've been on levonorgestrel IUS for almost 15 years. And if we look at the cost effectiveness, hysterectomy still remains more cost effective because now we're putting 3 IUSs in this period of time. If we look at the efficacy of ablation versus levonorgestrel IUS at 2 years, they're fairly equivalent. However, the reduction of mean menstrual blood loss is greater with endometrial ablation. And we do know that there are side effects despite it being a local measure, especially in the first 6 months, such as weight gain or perceived weight gain, irregular bleeding, breast changes, headache, cystic activity, or even skin changes. How about hysterectomy? So certainly, again, hysterectomy still remains the most satisfying procedure for women because the bleeding is done. There's no more futzing and messing around with 85% or 90% improvement. But there are greater complications, certainly from a surgical perspective, potentially pelvic floor dysfunction, a longer hospital stay. Endometrial ablation is half the cost, but again, around 4 to 5 years, that cost may equalize because the failure of endometrial ablation starts to come up. And in younger patients, less than 45, hysterectomy may be a more cost-effective solution because they're not going to have 2 or 3 IUSs in that time frame. But there's also part of loss of work, of recovering from a hysterectomy, return to function, and all of these quality of life measures, QOL, were not assessed. So where are the failures of endometrial ablation? So certainly women less than 40, unless there's coexisting medical conditions. I work in the Greater Toronto area. We have a high blood dyscrasia population. Those patients, even though they're 35 or 38, in terms of their ability to tolerate a major surgery like a hysterectomy is much more dangerous. So we will still offer it to women less than 40, but we know that their success is lower. 40 to 45, we do see even in that age range that there's a relative risk of, or odds ratio of 1.8 to 2.4 will go on to have a hysterectomy compared to women greater than 45. So if we were to pick an ideal candidate, we like to see women over 45 because sometimes that will carry them nicely through to the menopause. If we look at prior tubal ligation, there's a relative risk or a hazard ratio, HR, that will go on to have a hysterectomy, mainly due to pain. And we do see that post-tubal ligation syndrome in about 6% of cases. So understanding pain is very important before offering women endometrial ablation. Just a comment, their adenomyosis used to be a contraindication for ablation, but their recent review suggests that may not necessarily be true. So I think you have to talk to your patients about their expectations, and I think setting the goals is very important. So what's out there? If we look at techniques, Caviterm Plus, which is heated saline, Thermoblate, which is heated glycerin, microwave ablation, the NovaSure, which is radiofrequency, her option, and ThermoChoice 3 is now off the market. I think in the UK it's off the market as well, is it? The balloon, yeah. So they just stopped offering it. If we look at conventional resection or rollerball, there's sometimes debate, should we resect the endometrium or should we just rollerball it? And they're equivalent in terms of success. If we look at the 1-year rate, about 48 to 53%. And that's an important number to understand because I think people have an expectation that it's 80 or 85%, but only about half of our patients will actually achieve amenorrhea. So establishing the goals of reduction in bleeding and not loss of bleeding is very important. But the satisfaction rate is very high, almost 80%. The repeat surgery rate about 1 in 5, and then still that hysterectomy rate about 11%. So ablation versus rollerball and resection are the same. So how do we compare hysteroscopic endometrial ablation, be it through either of those techniques, versus global? And again, no statistical differences between these two. The amenorrhea rate is roughly the same at 1 year. At 2 to 5 years, about 50%. Satisfaction rate, very close, about 90%. At 2 to 5 years, about 87%, and the reintervention rate's about the same. This is a meta-analysis of 21 RCTs and it's a Cochrane review. So if we look now at what is different, so with hysteroscopic ablation, less equipment failure. This was mainly due to first-generation devices. I think most products are into second or third-generation devices, so they've tweaked it to make it more foolproof and less prone to challenges plugging this or pressing that wrong button. Less nausea and vomiting in the perioperative period. We can do 2 things at once. You can treat a fibroid and ablate. So if you've got concomitant disease, definitely there's advantages over the conventional resectoscope. Shorter procedure time, less anesthesia required. That's again shown a little bit with that, but we feel that the data is shifting over to the global endometrial ablation side. We do see faster recovery to normal activity, lower incidence of uterine perforation, fluid overload, cervical laceration. And the other aspect is less technical skill. So resectoscopic surgery can be technically quite challenging to do and very risky because if we perforate the uterus and there's bowel on the other side, now you've got to do a laparotomy for these patients. The technology was developed to facilitate people with less skill to also offer it. So those with greater skill can do it very easily. So what are the complications? So if we look at conventional resectoscope, they're similar, about 2.5% versus GEA, about 2.5%. So perforation, much higher rate with resection compared to global endometrial ablation, bleeding, hematometria, fluid overload. So fluid overload becomes an important aspect, looking at electrolyte imbalance. Obviously, when you're using a resectoscopic tools like monopole or energy, we have to use a non-conductive fluid in terms of fluid absorption. And obviously, with endometrial ablation, we've opened up all these vascular channels so that they can take on a lot of fluid very quickly. And with the global endometrial ablation technologies, we avoid a lot of that. Other complications such as pelvic infection, endometritis, myometritis are all very low. There's something called the MOD database, which is manufacturing data looking at complications or adverse injury. And the biggest risks with this, because it's not under direct vision, is bowel injury, and mainly due to delayed recognition. So if we look at most industry, they do suggest doing a pre- and post-operative hysteroscopy with ablation, with the diagnostic scope. So how do we reduce the complications? I think, obviously, patient selection is paramount. With the prior cesarean, with one, we can definitely do it. 2 or 3 is sort of at your own discretion. There's no data to say, looking at thickness, if it's certain thickness that we can offer it versus not. I think in the context of the rising C-section rate, we have to acquire more data on this question. They've had a classical or upper segment C-section. It's contraindicated due to weakness of the uterine musculature. They've had a transmural myomectomy, a corneal ectopic, or septal surgery, unification surgery. Generally, they're contraindicated as well for global endometrial ablation. So which global endometrial ablation is the best? So certainly we look at non-resectoscopic endometrial ablation or GEA devices, global devices. They're similar in terms of satisfaction, clinical outcomes, and safety profiles. So no matter what the companies would like to advertise to you, they're pretty much about the same. There are some new emerging technologies that do combination of therapies where they do heated fluid plus radiofrequency. And I think that may prove to be better, but we still don't have all of that data yet. There are very few head-to-head comparisons comparing global endometrial ablations to each other. But by far, NovaSure, which is a radiofrequency ablation, is the most studied device to date. So if we look at NovaSure, and so this is now dilation. And in the outpatient setting, dilation is the most painful part. So by reducing the diameter of dilation, we actually improve the patient experience. So NovaSure, the old generation is 7.2 millimeters. The new generation, which just got released this year, is 6. And there's a meaningful difference of not needing to go that far. The benefits are it's very rapid treatment. The maximum treatment time is 2 minutes. And it basically uses radiofrequency to assess the impedance of the lining. And sometimes it'll shut off at a minute or 60 seconds, especially if you pre-prepared that lining. High amenorrhea rate, so again, 50%. There are some limitations to how big the cavity can be. So generally 6 to 10, maybe 11 centimeters that you can push. Challenges are with the technical aspect of putting the device in. You have to kind of know how to seat it properly. So it's about seating that mesh array to fit that cavity as well as you can. So her option is cryoablation at 90 degrees Celsius, so smaller diameter size, 5.5, but very long treatment time, 10 to 18 minutes. So minimal anesthetic because of less dilation. But what we found in the longer procedures is at the 7 or 8 minute mark, a lot of patients start to cramp significantly, and it's very hard to chase after that in terms of pain. Same with the thermoblate, 3 minutes, but sometimes it can go longer. Direct visualization, the fluid with the hydrothermoblate, they've moved on to, I think, 3rd generation now. Some of the fluid, unfortunately, leaked through the cervix and caused vaginal burn, so it's not a contained fluid system. ThermoChoice 3, which was really a product that was used quite well, was a balloon-based device. So with the balloon-based devices, they can fit in a regular cavity. So if you've got smaller polyps, fibroids, or distortion that can fit. Thermoblade is another balloon-based device, short treatment time as well, and then Caviterm. So if we look at this anesthesia requirements or the OR setup, I think for the most part, for hysteroscopic ablations, resectoscope, they're going to a general anesthetic or a regional because we're dilating up to 10 millimeters. But however, it can be done, and we've done it with paracervical block and conscious sedation. But oftentimes it's done in the operating room in terms of setup. But I think we can move those things out. But in terms of anesthetic requirements, they are generally greater. If we look at GEA, it's certainly commonly done with just paracervical block, with or without conscious sedation. It can be done in the office just with oral sedation, and oral analgesia, and often it can take that patient out of the operating room setting. What we comment about here just is something called vocal local. That's a term that we use in terms of supporting a patient through a painful experience. And if we look at paracervical block versus supportive measures, they're essentially equivalent. So we mainly use paracervical block for post-operative pain relief as opposed to intraoperative pain relief. So what are the challenges? Certainly there's cost issues in terms of the disposal costs. There's no provision sometimes to a hospital or an industry to make up for that cost difference. If we looked at studies, we're probably close to 800 to 1,000 Canadian dollars for all of the disposable costs with the global endometrial ablation versus a resectoscope, we're probably about 300 with the loops. So it's almost 2.5 or threefold the cost. In a private healthcare system or a mixed system, it's often offered through insurance companies because you've taken the patient out of the costly operating room. So from a health economic perspective, it definitely makes sense. But we do see a trend in Canada where these procedures are still done under general anesthetic. So the cost-benefit analysis gets lost in that setting. I think looking at the procedure room, if you have a hospital that has a procedure room, like a colonoscopy room or a block room, this is very advantageous because you've taken them out of the operating room, so the cost of running that operating room is saved. The turnover time is saved. You don't have to use the common anesthetic recovery space. And so that's probably the most cost-effective and safer method. So if there's a complication with the anesthetic, the anesthetist is in-house, they can come right away as opposed to being in your office where you have to call 911. Obviously choosing the right patient and then making sure the rooms are set up accordingly. Is there Escher available in Kuwait? No. Okay, I'm going to skip over this. But just to do a quick education, it's been Health Canada approved and FDA approved since the early 2000s, and it's a coil that expands and occludes the tube, mainly due to ingrowth of tissue as opposed to serving as a complete plug. But they do require confirmation tests as well after. It's made out of a nickel titanium coil that expands with polyethylene fibers, and this is the handheld device for it. They're visible on X-ray, ultrasound, MRI, and CAT scan. It's a very nice procedure. There's a lot of controversy now with it in terms of some of the associated risks. This is with a 5.5 millimeter hysteroscope that has a 5 French operating channel, and it's just introduced into the cornua. And so with these procedures, we don't even do formal dilation. We do vaginoscopy or touchless examination. So we do know that the multiplicity of grasping the tenaculum, dilating, removing, and then introducing causes more pain. So trying to avoid all of that. We use a Toki scope, which is an angle scope, so it does facilitate entry. And then we slip the sheath into there. And it's literally a 2 to 4 minute procedure. And this is how it looks in real-time view. And that's it. So tissue ingrowth is the main mechanism of action. The pearl indices in their pivotal studies were very high, and I think some of the controversies is that there may be some unintended pregnancies, mainly due to poor follow-up, patient education, not being on a reliable contraceptive for the 3 months that it takes for the tubes to close. It's MRI safe. If you ever see patients coming from abroad with an Escher, it's been tested at 1.5 Tesla, and I think the 3 Tesla is coming out, and this is just HSG, and it can also be seen by sonography without saline infusion. From an economic perspective, there's still benefits even in a public healthcare system like Canada. The cost savings are more nominal, but obviously there's still benefits. Length of stay is important. So for all of these ambulatory procedures, this is the unknown research, I think, that still needs to be done in terms of how fast patients can return to their life. Obviously, these were some of the complications that happened. This was in the front of the JMIG, Journal for Minimally Invasive Gynecologic Surgery. Obviously, we can see, one of the pivotal turning points in one of our states or provinces was a patient undergoing a laparoscopic tubal ligation, had a retroperitoneal vascular injury, and succumbed. And that was such a drastic event, right? Because it's not without risk, and that allowed the public system of that province to then adopt this technology. So again, we see the complications, but we also see complications with laparoscopy. And I think looking at expectations, there's a black box warning now for ESURE in terms of the importance of counseling these patients. But we do see complications such as pain, failure, perforation, migration, or expulsion. And that can happen up to 6% of cases. And if that happens, then we need to obviously find out where it's been. So I'm just going to fast track that. So now advanced hysteroscopic morcellators. Coming back to the endometrial hyperplasia talk, so this really is a segue to this discussion because access to doing these procedures quickly is very helpful for the diagnostic challenges with hyperplasia. And we found in our clinic that that's predominantly what we're seeing as opposed to reproductive age women with heavy bleeding. We see fertility patients and we see the postmenopausal women with hyperplasia or polyps. Based on our 4 years now in this program. They're small caliber devices, so coming back to the pain with dilation, as low as 3 millimeters up to 9 millimeters. The non-electrical mechanical morcellation, so we can use saline, so you can allow up to 2.5 liters of absorbed fluid before you get into complications of pulmonary edema, as opposed to a liter with a non-conductive fluid in terms of hyponatremia. Certainly the benefits have been proven, it's effective. Obviously you have to choose the cases well. You can get complete resection with appropriate case selection. There's less dilatation of the cervix, less pain, so we can really facilitate a conscious sedation protocol, and then shorter treatment time. So the advantages are distension media. We've seen electrosurgical cords that have been fractured. We've had fires. We've had fires in our face, in our eyes. We've had fires on the drapes and patient burns, so you cannot ignore the risks of electrosurgery and thermal tissue damage. So adhesions and scarring. So if we look at monopolar current and fulguration in the fertility realm, again, no RCTs. They're more prospective cohort studies. With the fulguration, there may be more adhesions compared to a mechanical procedure or even bipolar. So bipolar technology creates a vapor plume. So in terms of the fulgurative effect, it may be less. So looking at fertility cases, that may be beneficial to you. Fluid absorption and perforation risk with the advantages. One of the challenges with resectoscope is you have all of these chips in your field of view, and you end up sometimes ablating the wrong area, going deeper. So this continuously removes the chips in your field of view. And if we look at the time of procedures, 18 minutes on average to almost an hour. Surgeon ease of use, so learning curve, so for education perspective, can avoid general anesthetic, and then shorter recovery time, so shorter length of stay. So here's a case. So this is using a 6.25 millimeter hysteroscope. The patient has just received conscious sedation in a large fibroid. So even like the prolapsing polyp, prolapsing polyp, they're very hard sometimes with the resectoscope because you can't work within the canal of the cervix or the lower segment. But with these devices, we truly can. And so essentially it's a reciprocating and oscillating saw that has a suction trap within it. And it's very fast, right? So we are always in constant communication with our anesthetist. And so the field is clear, right? So it's as it's resecting it, it's sucking it into the chamber and collecting it in a sock or a tissue trap. Questions have come up where can the pathologist still interpret cancer? And the data is clear that they still can. It's not like we send polyps whole anyways. We always send them in fragments. So the pathologist can still interpret from a diagnostic perspective cancer or hyperplasia. And this is with a third-year resident who, I think this was her second time doing this. Yes, so it's a very teachable skill. So mechanical versus electrical, saline, continuous visualization, no chips, inserted only once, so there's no more back and forth. Outpatient setting, lower skill level required. Disadvantages are the expense, challenges with control of bleeding. There is a new generation device that's probably coming to market where it will have within it a bipolar tool so that you can do spot coagulation as required. And if we look at pain, so I think one of the big impetus to do this was to help with pain, was shorter procedure time and lower pain scores. So I don't think it's a replacement for mono or bipolar hysteroscopy. I think it's another thing in your armamentarium. I think you have to select cases. I think if I were to advise which cases to select, type 0 myomas less than 6 centimeters, type 1 myoma less than 4 centimeters. The data suggests that after this number, that the incomplete resection rate can approach about 15%. So I think if you keep the sizes under here, you will succeed. And then preoperative management. So we utilize GnRH analogs or OCP, danazol, progestins to pre-treat to reduce the endometrial thickness and reduce the absorption. Intraoperative vasopressin, we use tranexamic acid for large fibroids, and even rectal misoprostol. And this is just 2 minutes on patient flow. So it's really, the goal was to provide effective, adequate sedation and analgesia, and really to facilitate a high quality experience and reduce hospital stay. So we use a conscious sedation or neurolept anesthesia plus paracervical block, but again, we can do GA with LMA or endotracheal tube or spinal as required. We really choose more healthy patients, so ASA class 1 and class 2, but I think that paradigm will shift to push on to class 3 because the obese population really benefits from doing this way. But we can sometimes do a spinal in these patients. We still do an NPO, nothing per os protocol, although it's being reevaluated. As you know, there's a movement of enhanced recovery after surgery protocol, so we're probably pushing to clear fluids on the morning. We preload them. This is preoperatively with Tylenol and celecoxib or any NSAID. There's good evidence to support that reduces postoperative pain. So she's brought pre-medicated with her NSAIDs, paracetamol, acetaminophen. We position her while awake into a dorsalithotomy. We initiate the sedation with the support person by the side. There's constant communication between the patient, with the patient by the surgeon, as well as with the anesthetist. So as we're going to infiltrate with the block, or if we're going to dilate, they can ramp up or ramp down their protocol infusion. We do vaginoscopy as much as we can, and then we only do the formal dilation for those procedures. Again, we're a teaching center, so we do a lot of things by the book because we want to obviously support the product and how it was designed, so we don't skip steps as well. In terms of what we use, so you don't necessarily need an anesthetist. We fortunately have one, so if patients don't do well, we can transition them to an LMA or a general endotracheal tube. But these are commonly used across our country, Versed or midazolam, and fentanyl, and then we can use propofol. So some centers, they can only use propofol if you have an anesthesia assistant or anesthetist, and then we use ondansetron for high-risk patients. Post-op, we continue with the acetaminophen, narcotics such as oxycodone and fentanyl. If we have a lot of nausea, dexamethasone or ondansetron. What we found when we were doing the balloon devices, which were 8 minutes long, is that 6 to 8 minutes, we were chasing their pain, and they were in excruciating pain in the recovery bay. And we found buscopan, which is a mixed narcotic, very helpful in this case, in this setting. So my tips, if you're going to set this up, is pick the right team. I wouldn't open this up to everybody. Pick 2 to 4 gynecologists who are very supportive in their vocal local ability to communicate with patients throughout the case. The right anesthetist who's not going to knock the patients out, but yet give them enough support personnel that are, again, well-versed in the vocal local. Find the right space. So procedure room is ideal, and make sure you have good recovery bay. Establish a common protocol, so discuss and establish it with all members. Choose your tools so you have everything at your disposal, and then select appropriate cases, especially the easier ones initially until you get your steam up. I'll take 3 seconds to thank everyone for this unique experience. It's been a pleasure to be here. And any questions?